Hi guys, and welcome to Gallbladder Basics. My name's Steven. Let's get started. So first things first, you're going to be using the curvilinear probe for this exam. You're going to start out by putting the indicator towards the patient's head, and you're going to go just below the xiphoid process, and you're going to do something called the costal sweep. So that's basically where you sweep the probe down the costal margin, just the inferior rib margin, to the patient's right side. The reason we're doing that is because we want to look along the margin of the liver right here until we encounter the gallbladder. So most of the time this method is going to be successful. As you slide down the probe, you're gonna encounter this kind of view right here, where you see the liver in front, and then you see the gallbladder right behind it in the gallbladder fossa. So remember, this is towards the patient's head, so liver down here. What that is gonna look like on ultrasound, because this is the AP, so this is towards the patient's head, the liver's there. Here is liver margin in front, and here's gallbladder right behind it. And this is obviously your ultrasound probe with the indicator pointed towards the patient's head. Side by side with the image, you can see you've got liver here and you've got gallbladder right here. So as you do that costal sweep, you're going to keep sweeping across the margin, looking at the liver the whole time until that gallbladder comes into view. Now, say you do that costal sweep, and this is all you're seeing. This is basically bowel gas, and this can happen a lot because people's gallbladders can be a little bit higher, or they can just be really gassy at the time of you doing your scan. So the two things that I would recommend doing is first, have the patient take a deep breath and hold. So do that costal sweep as they're doing that, and you probably will see the gallbladder come into view. The other thing you can do is have the patient roll over onto their left side, and this will move some of that bowel gas out of the way from where you're trying to scan, and it will definitely help you acquire better images. So if you do have them roll over to the side or take a deep breath, and now you can see liver and you can see kidney or other structures, but you can't see gallbladder. There's a couple recommendations I have for finding where the gallbladder actually is at. So the first is to do this kidney to gallbladder. And if you watch the scan right here, you see that first you're looking at the kidney, which is right there, and then all of a sudden you see the gallbladder come into view. And what that is they kind of lay in the same plane at the inferior margin of the liver. So if you image the right kidney with the indicator pointing towards the patient's head, and you slide across the abdomen towards the anterior abdomen, keeping the inferior margin of the liver in view the whole time. As you can see here, they keep the inferior margin of the liver in view the whole time. Once they get more anterior, they find that gallbladder. So this is kind of like a reverse costal sweep, except you're using the kidney fossa to come in contact with the gallbladder fossa. The other thing that you can do is find the MLF, the main lobar fissure, which generally connects the neck of the gallbladder towards the portal triad. So it's this bright white band of tissue you see at the beginning of this clip right here that goes towards the neck, from the neck of the gallbladder to the portal triad. So if you're fanning through the liver and you see that bright white stripe, you can try to trace that back to either the portal triad or the gallbladder neck. This is a little more difficult though, and I really find that the kidney to gallbladder method works almost all the time. So what if you've had them roll and you're having them take a deep breath, and this is still all you see? You still just see bowel. Well, that's where this comes in. This is called the X-7 technique. And that is basically you go subxiphoid and you just move 7 centimeters laterally and plop the probe down on the patient's side. You're going to basically be in this kind of view with the liver and the ribs. So you're going to be much higher than you were with the subcostal sweep. And you're going to have to get through the ribs to see the gallbladder, but you can pretty much always find it if you just move 7 centimeters lateral and plop it down there on that rib space. The problem is, as you can see, now we have this rib shadowing that's making our images a lot worse. So you see liver here, and you see gallbladder here, coming into view right there, but it's a lot harder because of those rib shadows. So what I usually do if I have to do the X-7 technique is I switch over to the phased array probe. And the reason I do that is because you can see it has a smaller footprint up here. So you can actually kind of put the between rib spaces, and it's a lot easier to fan and see what you're looking for. So here's the same X-7 technique, except you can see I'm using the phased array. That little pyramid up at the top says that it's the phased array rather than the curvilinear. And now you can see my rib shadows are a lot less obvious, and I can really mostly image the gallbladder without much of a problem. So basically, image in 2 planes after you find the gallbladder. Look for stones. Stones that don't represent pathology. A lot of people have stones, and if they're asymptomatic from their stones, you don't need to do anything about it. you need to measure the anterior wall. And this is because as sound travels through the gallbladder, it's a fluid-filled structure, it will speed up. When it hits the posterior wall, it takes a little extra time to slow down. So you have posterior acoustic enhancement at the posterior wall, so it will appear falsely large. So when you're measuring the gallbladder wall, you always have to measure the anterior wall. So take a second and screenshot this or take a picture. I know it's a lot on one thing, but this is basically how I approach gallbladder imaging. So you start with that costal sweep. If you can't see the gallbladder, then you try the breath hold left lateral position. And if you do see the gallbladder, then yeah, go ahead and image it in 2 planes, get the anterior wall measurement, look for stones. If you still don't see the gallbladder, ask yourself, do I see liver? And if you don't see liver, then that's when I go to the X+7 and I just use the phased array right off the bat. But if I do see liver, and I'm just having trouble figuring out what the gallbladder is, I use the kidney to gallbladder or main lobar fissure to gallbladder techniques. And that's because the gallbladder can be really contracted, especially if the patient just ate or something. And if you use those techniques and pay attention to what you're looking at as you're sliding along the liver margin, or go find the main lobar fissure and see it pointing to the gallbladder neck, you'll usually find a structure that represents the gallbladder that just looks different than what you're anticipating because it's contracted or a little abnormally shaped. Or whatever. So that is basically it. That's all you guys got to do for gallbladder. It's one of the hardest scans to do, really, to be honest with you. So don't get discouraged as you're learning this. I promise you'll get better. And I'll do another video covering the common bile duct because I know that's a sticking point for a lot of people. But I promise that is pretty easy too, and you will get good at it. You just got to practice.